Hello and welcome to a special edition of sMater, a podcast by clinicians for clinicians, brought to you by sMater, an Australian leader in healthcare for more than a century. My name is Glenn Minturn. I'm excited to join you as we meet some of our clinicians and deep dive into specialty areas from across sMater's facilities in Mackay and Townsville. Today, I'm coming to you from Kutharinga, the land on which this podcast is recorded. And in recognition of Ovarian Cancer Awareness Month, I'm joined by Dr. Sally Aubrey, an obstetrician and gynaecologist at Mater Mothers Private Townsville. Dr. Aubrey grew up here in Townsville, and after extensive training and study in hospitals around Queensland, she knew she wanted to set up practice in her hometown. Dr. Aubrey completed her studies at James Cook University's School of Medicine, graduating with honours, winning the Obstetrics and Gynaecology Prize and receiving an academic medal. Today, she's joining us to talk about the detection and treatment of ovarian cancer, as well as the concept of perimenopause and looking beyond hot flushes as symptoms.
sMater.
Caring for the community for more than a century.
Innovators in health, education and research.
Home to world-class clinicians.
State-of-the-art facilities.
High-quality, patient-centred care.
Australia's largest and leading maternity provider.
Turning scientific discoveries into
Educating the
life-changing
nurses,
outcomes.
leading healthcare advancements.
We are sMater.
We are sMater.
We are sMater.
This is sMater.
Sally, great to have you with us today. Welcome to sMater.
Thank you so much. It's great to be here.
Well, as I mentioned in the opening, it's Ovarian Cancer Month. We're taking a deep look into that throughout today. And I know for you, this is quite a personal thing. It's something that certainly has a place in your heart, doesn't it?
Yeah, it really does. As a clinician, I've unfortunately had to diagnose many people with ovarian cancer. Some of those people have been patients that have been previous patients of mine that I might have helped, birth their babies, and this has come to another aspect of their lives that has obviously got a whole different emotion and management. As well as that, of course, I've known people, friends and relatives who've had ovarian cancer. And actually more recently, as you know, late last year, we held an ovarian cancer fundraiser, a luncheon in Townsville, where 120 of our friends, family and people we didn't know attended and helped us raise quite a lot of money for ovarian cancer research.
That was a fabulous day at the Silver Linings Long Lunch. It was a beautiful day, and I think we're all pretty amazed with the generosity of people who wanted to put money into research to rid the world of this horrible disease.
Yeah, it was really lovely. I mean, our tickets sold out in less than a week, and a lot of the people who bought tickets were ovarian cancer survivors themselves.
Before we delve into some of the real technical elements of what we're here to talk about today, I thought it might be fitting, given we have this awareness month, to just talk about, those potential signs or symptoms that people themselves or people's patients might be looking at when it comes to ovarian cancer, because this is a really tough area. There's not a test out there that's going to help it. So can you help us out with maybe some of those symptoms or signs that we should be keeping an eye out for?
Yeah, it's very non-specific. That's the worst part about ovarian cancer, and probably one of the reasons it's very late to get diagnosed. They are, and I have to say, unfortunately, and I don't think this is doctors' fault, but a lot of patients who come to see me with late-stage ovarian cancer kind of tell me they've been mentioning to their doctor over and over again these kind of non-specific signs.
Yeah.
So they talk about bloating, and I feel like what women, I don't know, you may not know this, Minty, but a lot of women think that they're bloated a lot of the time. But I think if a woman is consistently reporting bloating, that's not normal. That's really not. Sometimes they'll have some bleeding, vaginal bleeding, for example. It'll be things like bowel symptoms. So then it can get really tricky. Do you investigate for bowel problems or ovarian problems? But I think if a woman is reporting bloating, that is a number one. That should be a red flag for any clinician to think, oh, look, does this woman have ovaries? And maybe, interestingly enough, even if she doesn't have ovaries.
Yeah, right.
Yeah, because a lot of women have procedures such as hysterectomies, and something we've spoken about before. And sometimes the ovaries get left and sometimes they don't. But And a lot of clinicians might not know that. I mean, when we do surgery, there's not like there's a dotted line where one organ finishes and another begins.
Yes.
So sometimes a small amount of ovarian tissue can be left behind. So if a woman has, in fact, reports bloating, I think a pelvic ultrasound is the number one. You can't go past it.
Do you think that one of the big issues is there is so many things that, as a woman, and I'm not one, but you go through, and everyone starts to think, well, is this menopause? Is this perimenopause? Maybe I'm bloating just because I'm a woman and I'm at a certain stage in my life. So it takes a little while for them to trigger to get to a point where maybe I need to flag this.
Definitely. And even if they think there's a problem, maybe their doctor doesn't think there's a problem. Maybe they don't think there's a problem and their doctor does and they're reluctant to act on it.
Yeah.
Maybe they think there's a problem but their 3 best friends had bloating and they say, look, that's just normal.
Yeah.
That's just being a woman. You're overreacting. What has happened in the same family is important. So if sisters have had that, they're like, don't worry about it. It's a minefield, to be honest with you. Yeah,
and mostly it's intuition in your own mind that says something's not quite right, and if it's not quite right, you should ask the question.
Yeah, because I think a patient who has bloating and I feel like a lot of women tell me that they have bloating, but that's because I'm a gynaecologist, and by the time people see me, they're coming with a period problem or a menopause problem or something more tricky.
Yeah.
So I'm not a good, reliable indicator because I think every woman has bloating and I'm always worried about it. But I love it when I see a woman for something else and she says, no, I have normal periods, no bloating, I've never had any of this kind of stuff. But equally, I think a lot of women actually don't have bloating and they don't have pelvic pain and they don't have abnormal bleeding. And in those women especially, if you're a clinician and your patient tells you they have those things, of course you might think bowel problems. I think that's a whole other area.
Yeah.
But I would be thinking pelvic ultrasound, look for ovarian problems.
You mentioned that you tend to see a lot of the ladies who are in the late stages and, it's at a tough period. So obviously it makes a difference if you can find these things in the early stages, and that's going to change diagnosis, treatment and outcome as well if you can get it nice and early, because that's the benefit of finding ovarian cancer in particular early, right?
Yeah, it is really difficult to do. So we don't have any early detection systems in place really, and I get a lot of sometimes I get patients who maybe their mum had an ovarian cancer, maybe I might have just one relative, and the clinicians who are watching this will know that generally speaking for breast and ovarian cancer we would kind of think about screening someone if they had multiple relatives or if they had specific genes that might be relevant. Other than that, though, a lot of women come to me and say, I'm worried I might get an ovarian cancer. I've asked my GP for an ultrasound and they've said no. And I think there is a complexity there because one of the things that a lot of clinicians will think of is, well, there are some blood tumour markers we can do. Usually they only show up once there's a cancer in place. Yeah. But still, if there's an early cancer, we want to catch it. But there's nothing that you can do to screen for it. So a lot of people would know, even males would know that there's a pap smear screening test. And actually, interesting point, a lot of doctors might not realise that their patients think a pap smear test for ovarian cancer. So you know that it doesn't, but they don't necessarily know that. They think they've had a pap test and so they're fine. They're not going to have that. That's a whole other issue. But a lot of patients think if I can just have those blood tests that you mentioned, doctor, and an ultrasound, do that every year, surely then I won't get ovarian cancer. And the reality is the government's looked at this. They've looked at could we actually possibly screen every woman every year at a certain time? And the answer is, of course, there's no way our health budget would ever be able to afford that. It would be incredibly intensive. There's not even enough people do the ultrasounds. And then the other problem is if you did that, just say I had a test in January and my tumour markers were normal and my ultrasound result was normal, by September I could have advanced ovarian cancer, which is terrifying. It's very quick. And as you mentioned, I think your question was, what difference does it make to be detected early?
Yeah.
And essentially, if you are at stage 1, it's confined to one ovary. It hasn't spread. Commonly it spreads to a second ovary. That's kind of stage 2. Then we head out to the nearby organs. That's stage 3, and stage 4 is when it goes somewhere distantly. And I'm sure all the clinicians listening and know that. But if it's caught at stage 1, it's about a 10% chance of I should reverse that. A 90% chance of 5-year survival. So at 5 years, 90% of people would still be alive and well. And if you wait till stage 3 or 4, it's about 25 to 30%. So it's very, very, very tough going if you catch it late, which most people are caught late.
So why is it that ovarian cancer is so hard to detect? Why is it so difficult?
We don't know really. There is a whole other issue that we probably can't get into, which is that often women's pain and discomfort is a little bit devalued. I don't think I'm alone. I think most clinicians listening would see the increasing evidence that kind of when women complain about something, as doctors, we probably haven't been well trained to take that seriously. That's a whole other political minefield, maybe not to get into. But the lack of early markers, the lack of an effective screening test, it's not at all like pap smears and cervix screening. That's been a huge success, and it really came primarily from Australian research that now almost nobody in Australia will die of a cervical cancer. Of course, that's, don't get me wrong, people do. But if people have pap smears, the chance of that is almost zilch.
Yeah.
There's nothing like that for ovarian cancer, unfortunately.
Let's talk about some of the misconceptions around hysterectomies and what that means with ovarian cancer, because, again, the world is full of misconceptions.
Yeah.
Where do you sit on this area?
So a lot of clinicians, especially if they trained many years ago, I'll get this kind of idea, or patients will say to me, well, I told my doctor I had bloating, but they kind of said, well, you've had a hysterectomy, you can't have ovarian cancer. And that's probably left over from previous history where traditionally if we were removing someone's uterus, maybe they have heavy periods, the doctors were thinking, especially that I suppose also if you think about it, the surgery was more complex. We can do keyhole surgery now, you recover more quickly, but once upon a time do a hysterectomy, it was like a cesarean style cut, much bigger. Wow. The recovery was longer. So a doctor might think, we're already going in to remove the uterus, let's remove the ovaries while we're there. But I think the issue is we've figured out that doing that to a woman, especially under the age of 50, just because of some perceived thought that she might have ovarian cancer in the future, puts her through a lot, like essentially what we call a surgical menopause. So, if a woman is 42 and otherwise healthy, but everything else we've tried to control her periods hasn't worked, we'll opt to perform a hysterectomy, but we would counsel that woman, unless she had a strong family history, to keep her ovaries, because otherwise she's going to become... We were going to talk a little bit about menopause later, but that would essentially sometimes submit her to all of that much younger and some associated risks. So if you're an older clinician, and even if you're not actually, some doctors do tell me, oh, well, I just presumed because she'd had a hysterectomy, her ovaries were removed, and that's no longer our typical course of action.
Cancer Australia reported an estimated 1,815 Australian women were diagnosed with ovarian cancer in 2022, which accounted for 2.5% of all new cancers in females diagnosed in that year. Comparatively, roughly 1,016 females died from ovarian cancer in the same year, accounting for 4.6% of all female cancer deaths.
So, Sally, looking at other methods of diagnosis, when do tumour markers in the bloodstream or ultrasounds become apparent, and is there a method of early detection for those?
Well, it's not easy. Once a woman has bloating, one would presume an ultrasound is going to be helpful in diagnosis, because the woman would be bloated because one presumes the ovary has gotten swollen. Often the things we are looking for on an ultrasound, by the way, it's actually worth mentioning for the clinicians out there, are complicated cystic growths on the ovaries. So I get a lot of referrals for an enlarged simple cyst on the ovary that's been persistent over many months, and a lot of the clinicians out there, my colleagues are very learned in their general practice specialty. They know, oh look, I've done a scan on a woman, she's got a 5 centimetre simple cyst, let's just rescan that in 6 weeks, very likely to go away. But we'd be more concerned about a complex cyst with solid and cystic features.
Sure.
And if it's on both ovaries, even more concerned. So that would be immediate referral. Other features would be free fluid in the pelvis. So when you scan a healthy woman and you look at her uterus and ovaries, you shouldn't see a lot of free fluid around that area, and that's very apparent on scans. Again, another kind of concerning marker, and obviously if you see solid masses in other locations as well. So those would be the things. I think if a woman has no abnormal findings on ultrasound and she still has persistent bloating, I'd still think about referral, and then I would do those tumour markers. So my colleagues would all do commonly, there's one called CA125, which is the most specific, and cancer antigen 125 is elevated when the ovary is enlarged. So there's an area around the ovary called the cortex, and when it's kind of stretched, it tends to release this cancer antigen 125. So it's really important, if someone's referring to me, someone that's concerned might have ovarian cancer, do an early CA125. But again, I'm sure they're aware that it can also be it can also be increased in other conditions such as endometriosis and some of the other ones. So, but if you're concerned, early referral really important, and same with the other tumour markers that are commonly done. So there's CEA and CA 19.9, and I don't think I meet many doctors who refer to me that don't do all three of those. They're really important, but the other two are really looking at kind of other things that might cause the same symptoms. So they're a bit more specific for maybe bowel issues. So I can kind of go, ooh, is it really a bowel issue rather than an ovarian one?
All right, well, there's some important technical stuff in there, but what about genetics? Because we talk a lot about genetics, and you've already kind of brought that into the conversation. How much should a GP be taking that into account when they're doing a checkup?
Yeah, I think it's important. I don't think it is the be-all, end-all. So as we've said, persistent bloating, I keep talking about bloating, but it really is just so important to not to miss it. And a concern is all you need. So referral early for any concern you have about that. But genetics and family history do become important in a subset of people. So most people, or a lot of people, have heard of the breast cancer gene. It's called BRCA, and there's two of them, BRCA1 and BRCA2, and they are different genes, but can both cause an increased risk of breast and ovarian cancer. And if you have a patient with a BRCA gene, in fact, it's important to have counselling to them about what they can do long term, apart from the breast cancer issue, which I would leave to more learned people in that area, but it does particularly increase their risk of ovarian cancer. And I would say that you need to be including a gynaecologist in your referrals, even if there's nothing specific at that time. So often a patient will learn that they have the BRCA gene because they have some relatives who all seem to get one of those two conditions, breast or ovarian cancer. Someone in the family will have elected to have a test, and then based on whether or not that's a direct family member or not, you can be eligible for BRCA gene testing, and that can lead to a knowledge that you yourself have the BRCA gene. Once you know that, I think a lot of doctors are very good at referring off to a breast surgeon and like to at least speak to the patient about what risk there is and what risk reduction techniques are in place. But for ovarian cancer, for example, once someone's had their family, they might talk to a gynaecologist about the pros and cons of having risk reduction surgery to remove their ovaries. So, of course, that's complex. If someone's 35 and suddenly they're looking at having a surgical menopause, it's big decisions, but it can reduce their risk of ovarian cancer by 50% just by having that done. Oh, sorry, I should characterise that better. It reduces their risk of breast cancer by 50% just by having that done. And, of course, it reduces their risk of ovarian cancer by 99%. So it's difficult. Different people will look at that risk differently. What are the pros and cons? Is it really likely in the next 5 years that that's going to happen to me? What if I want to have more kids? It's a complex decision, but I think involving a gynaecologist is important.
So just to wrap up this part of the conversation, looking ahead to the future, what role is technology going to play in the earlier detection of ovarian cancer looking into the future, do you think?
Oh, I think as technologies get cheaper, it'll be easier to access BRCA gene testing and other genetic testing. It's important for me to stop here and remind everyone that BRCA gene is not the only important one. In fact, you can have a big, strong family history of ovarian or breast cancer and be negative. The whole family might be negative for BRCA gene. There are other unknown genes that can cause the same effect that we may not have a name for yet. Technology is complex, though. It always has its pros and cons. Like at the moment, you can go and order, even on the internet, gene tests that will give you spit all these numbers back at you. And I'm sure my colleagues have patients who've done that and come with the data and said, "What does it all mean?" And they're like, realistically, we don't even know. So technology is going to open some doors that we're not ready to answer, but usually that also creates opportunities. So I think it'll make genetic testing more accessible to average people, and also in our system where we have a public health system where the government always has to make a decision about whether to fund things. Is it really in the public's good to spend money on this? They're more likely to spend that money if it doesn't cost as much. So that's where I think technologies will take us.
A study currently underway by sMater Research and the University of Queensland is looking at a potential tablet treatment for ovarian cancer, which could be more effective and have fewer side effects than current chemotherapy. The study, led by Professor Brian Gabrielli, will build on his decade of work on melanomas, which established that combining lower doses of chemotherapy with a targeted therapy, taken in tablet form, can attack deadly skin cancers without the patient suffering the full usual effects of chemotherapy. Professor Gabrielli said the target of inhibitors in melanoma is also a very common feature of high-grade serous ovarian cancer, with preliminary evidence suggesting that, like in melanoma, the treatment is effective.
Well, Sally, of course, summer in North Queensland, it's hot. But I want to talk about a different kind of hot flush. It's something that I know a lot of people talk about, but can you give me a bit of background on the work that you do to support patients with menopause?
Yeah, it's a really common concern. And I think, again, we've talked about some things that might get a little underrated by people. I think people really understand when a woman or a man has pain, that's like, we can do something about that and, let me get you some medicine for that. But menopause, it's hard. Like, a woman says to you, I'm having a hot flush. You're kind of embarrassed. Like, really? Can you get that together? And, especially for males, that's a complex conversation. There's a lot of joking around in the community about hot flushes,
yes.
And it kind of reflects how we feel in the community.
Because it's not a joking matter at all, is it?
It's not. No, it's not. But it is awkward. I think it's awkward for women because they often don't really talk. We don't talk to our daughters about what it's going to be like to go through it. We're kind of not ashamed, but it's kind of embarrassing. It kind of heralds a new time in your life when you're moving on, and often it might coincide with your kids leaving school and suddenly you're an empty nester, and there's a lot of emotions and stuff going on. Plus, you're extremely hormonal when you're going through menopause. Sometimes I've wondered if I might be going through it a little early because what's my excuse? But yeah, so I would say hot flushes is huge in Queensland particularly, and a hot flush can last for 2 or 3 minutes at a time, and apparently your core temperature can drop by about 7 degrees in that time. It's really hard to hold on a conversation with someone while you're just completely changed. It's like you're moving to a whole new continent in 2 minutes, and so it's embarrassing. You sweat, you try to hide it. It's complicated, yeah.
But the thing is, it's not necessarily something that you are going to get when you get into menopause as well, because you don't have to have symptoms of hot flushes. I'm aware that some people can report they do, and some that they don't. So is there a diagnosis that you look for when it comes to working this out? Are there signs to look for outside of just hot flushes?
Yes, there's signs to look for. So brain fog is a big one. Women, I even have professional patients who work in high-flying jobs, flying in and out of our national capital, other places, really, really top-level executives who are like, I don't know if I can do my job. Like, I feel really, my brain, I've gone from being someone who is absolutely a type A personality, organised, to just feeling like I don't know where my car keys are. So brain fog is big. Also, I feel moodiness, and like, again, jokey, but it's not really a joke. Some women will actually be absolutely angry with everyone in their household, and they come to me and they say, I know I'm being completely unreasonable and I hate it. I hate myself. And that's awful, like, to think that they feel that way. So I would say they're the key things: hot flushes, brain fog, sometimes some blood pressure issues, but more specifically this kind of, again, very non-specific constellation of symptoms. Yeah.
And if you're sensing something, go and ask a professional. I think a lot of people tend to go to Dr. Google. I think probably better to go and see a professional when it comes to that.
I mean, and general practitioners are the starting point.
Yes.
They're very good at this. Yeah.
All right, let's talk about hormone replacement now. This is a topic that gets a lot of discussion.
Yeah.
Does it actually assist with menopause symptoms? And are there hesitations in the medical community about using that as a treatment?
Yeah, absolutely. There still are. It does work very effectively for the vast majority of people. And so the principles we use are try to use adequate replacement. So sometimes I'll meet people and their doctors put them on a tiny itty bitty dose, and then they say, well, this doesn't work anyway. I don't even know what I'm doing here. So I think putting people on a reasonable dose of medication and acknowledging what's going on for them. And medication's not the only thing, by the way. Lifestyle change, all the things we know we should be doing, not smoking, losing a little bit of weight. A lot of hormones are stored in our adipose tissue, our fatty tissue. So I often talk to patients very gently about the fact that all the things we're doing with medicines are one thing, but if you take it away from being a value judgment, I mean, we all gain weight around menopause. It's unfortunately one of those things that we have to work on. But I say, unfortunately, a lot of there's a weak form of estrogen that's stored in our adipose tissue. So if we can get rid of a little bit of that will help ultimately deal with this, which is a much better way than saying something like, you're fat and you need to lose weight. Like, it's kind of like you just lose your audience straight away.
Yeah, totally.
But back on the topic that you asked me about, hormone replacement does work very effectively. There's lots of options for treatment, but I do find there's a reluctance, and a lot of general practitioners will refer people to me to make that call. And patients come and they've talked to their friends and they've said, I've heard it causes breast cancer. So I have a kind of stock standard way I describe the risk to them. I talk to them about the fact that 1 in 8 women will eventually get a breast cancer. And if you think about that, that's horrible. If I'm seeing a patient in my rooms, I have receptionists outside and sometimes some people waiting in the waiting room. There might be 8 people in my rooms one day and one of us is going to get one at some stage. And that's horrifying data to think about.
Yes, absolutely.
That's not a great place to start, but that's where I start with the patient. And then I tell them that when I was at medical school, it was drilled into me almost every time, what are the 3 biggest risk factors for getting breast cancer? And unfortunately, it's being a woman and getting older and having a family history. So they're the 3. That's your starting point. And then hormone replacement gets this terrible rap because 70s, 80s, a lot of women were encouraged to be on hormone replacement. There was a very specific doctor in the US who was telling women, you'll be amazing, your skin will be great, you'll be more lovable because you're in a better mood. So I think every woman was on HRT, whether they really needed to be or not.
Yes.
And then the study was suddenly stopped because data came out that it caused breast cancer. And that wasn't very well managed and it spooked everybody, and a lot of clinicians are still recovering from that. But what I tell people when I'm speaking to them about HRT, because women are educated and smart and they can make a good decision. So I tell them 1 in 8 women are going to get a breast cancer. So just say we took Queensland Country Bank Stadium and we put 10,000 women in there and kept them there for the rest of their lives. It would be highly unethical, but just let's say we did it. So we did that, and unfortunately 800 of them would eventually get a breast cancer. That's just horrible when you put it that way.
Yeah.
So let's just say we built another stadium next door. We're even more unethical and put 10,000 more women in that stadium and waited to see what happened. But we also put them on HRT. So now we have 808 women with breast cancer. So we have 800 here who got it without HRT and 808 if you add HRT.
Wow.
So it's not really that big a difference when you think about it. And also there's about 7 fewer who would get bowel cancer and about 8 fewer who would get osteoporosis causing a fracture. So it's not as cut and dried. And if you present that to a woman and say to her, let's try HRT for 1 to 2 years, that's really not a really high risk timeline to try it. And then we can see if it doesn't work, let's stop it. You don't need to be on something that might even partially increase your risk if it's not helping. But if it's really helping, then what have we lost? And in 2 years, we can see if you still need it. If you still need it, we should continue it. But if you don't, let's not. And if you present that, women can make decisions for themselves.
So on that, as you say, you're going to take a couple of years to determine that. What if someone isn't suited to hormone treatment or there's no desire to go down that path? Are there other options that can be looked at? Yeah,
and of course that's where I will really start putting the onus back on the patient a little bit if there are lifestyle measures she can take. So exercise, especially weight-bearing exercise, is very helpful for mindset and mood and brain fog. I'll talk about the weight loss issue in a little bit more detail. But of course sometimes women don't already exercise and don't need to lose weight, so it's complicated. My colleagues and I sometimes go to the pharmacy and look a little bit around the room and think, how many of these supplements really do anything? If most people have a normal diet, they don't need a lot of the supplements that they go buying in the pharmacy. But menopause supplements are actually amazing. They can make a big difference. So there's a few particular ingredients, one called black cohosh, which have been shown in good meta-analyses to make a difference. So you can actually recommend to your patient to have a menopause supplement. It could make a big difference. And there's usually about 3 or 4 agents that are known to be effective in those supplements. And then as my colleagues would know, there are some non-hormonal treatments. Clonidine is a well-known medicine that works particularly with hot flushes and also can help with blood pressure a little bit at the same time. So I would often start thinking about clonidine or something similar like that for a patient. And then if you're kind of out of your comfort zone, then you could always start your patient on clonidine, especially if you don't feel comfortable deciding about HRT. Yep. And then that gives her something while she's waiting to see me that would be my thought.
The Australian Menopause Society notes that chemotherapy and radiation therapy for cancer or other conditions can cause temporary or permanent loss of menstrual periods, leading to potential menopause or infertility. Before the age of 40, this is known as premature ovarian insufficiency, and between 40 and 45 is classified as early menopause. However, it's important to note sometimes these effects are temporary and patients do remain fertile after treatment.
So the topics we've talked about today, cancer, menopause and infertility, they're pretty heavy topics to discuss. There's no doubt about that. But is there a light at the end of the tunnel for some patients? Have you had any recent extraordinary cases that sort of make you feel like we're going in the right direction?
Yeah, I have a patient particularly who lives in a rural centre who unfortunately was diagnosed with breast cancer at a young age. When you are diagnosed with that, you obviously have to go through chemotherapy that can limit your ability to even consider fertility. And she's now kind of in her late 30s and was also having to be on a medication, tamoxifen, for a prolonged period of time, which realistically can't. It impedes, as my colleagues know, it impedes periods. So, falling pregnant, what if being pregnant is a very hormonal state? What if that brings back the breast cancer? What are the decisions here? What if I get pregnant and then I get a breast cancer back? But and also the issue of how are you going to get pregnant? There's a huge impact on your ovaries from chemotherapy. But one of my patients, long-standing patients, recently had a baby, which was wonderful news. Wow. She had a little bit of fertility assistance, surprisingly much quicker than expected, and she succeeded. And I have another funny story actually, which I know my patient won't mind me sharing, even if she was to watch this. She saw me for some infertility problems after a cancer scare some years ago. She saw a colleague of mine for infertility issues and then came to me for pregnancy care. The pregnancy was uncomplicated. It was lovely to get to know her and her husband. And then she came to see me actually about a year afterwards and said, look, I just wanted to have a chat with you before we go back on our IVF journey. I was thinking about the fact that my periods are a bit all over the shop. They're kind of only coming 45 to 60 days, a bit hard to fall pregnant if you're only having a period every 3 months. But she told me, look, it's been 45, 50 days since my last one. So, what can we do to make this better? And I said to her, well, we better just do a pregnancy test. I mean, it just, stranger things have happened. And she told me how ridiculous I was. And it was positive. So I came back into the room and told her, well, I hope you're ready because you're pregnant. And she was thrilled, of course, because this means that she doesn't have to do this big complicated IVF journey, but it was probably a little bit much for her husband downstairs in the car when she came down and he said, what did Sally say? And she said, I'm pregnant. So it's, wow. I hope you're ready. So that was lovely though.
I can see that smile on your face. And as a medical profession, I understand part of that, but also just as a person, I mean, to be on this journey through so many different ups and downs, what's it like on a personal level for you to be on that journey with your patients?
It's great. I sometimes joke that, I go in and deliver babies in the middle of the night and patients are lovely. They always say, oh, you haven't had sleep. And I say to them, look, I don't come in and deliver kidney stones. I deliver babies. It's a pretty fantastic job. But apologies to my colleagues who do. But I do think it's not all sunshine and roses. Like there's a lot of sadness that we do encounter. And, who wants to talk about that? But you are definitely on a positive, negative journey with a lot of patients. And I think a lot of people think my job is just catching babies and holding babies. And that's kind of a very tiny part. I hand that baby off as quick as I can. Once it's out, I don't want anything to do with it. It's the mum that I'm about. So, yeah. Beautiful
answer. Well, just before we wrap up with Sally, it's time to introduce our favourite little topic. It is the checkup. So we have found out a little bit more about you as a medical professional. I think we started to learn a little bit more about you at the end of the last segment as well. But this one we get to find out a whole lot more. It's time for your quick fire questions. We've got 5 questions. Off the top of your head, don't spend too much time thinking about the answers. Okay. Let's find out what more we can find about Dr. Sally today. All right, you ready to go?
Yep, I think so.
All right, first question up. How do you want patients to see you?
Friendly, caring, approachable, accessible.
I'd tick all of those boxes. You're definitely that. How do you unwind or relax? Because I'm sure this can be pretty stressful. So what's your go-to for unwinding and relaxing?
I feel like wine is the wrong answer. But other than that, time with the kids and my husband.
Yeah, beautiful. How would you describe your handwriting?
Terrible, 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 and terrible. Yeah, and I'm left-handed, so it's even harder.
Do you have a theatre playlist?
Yeah, I do actually. It's got lots of old school music on it, 90s nostalgia, Alanis Morissette, stuff like that. But also we have a baby playlist. So we have, so of course a lot of mums are coming in for an emergency cesarean. If there's time, quite often I can ask them, is there something that you would really love to have us play? And they'll tell me. They usually can't think of it. So the next question is, what can we absolutely not play? And Recently we had country music and Shania Twain came on and we were like, quick, prepare the fast forward. We can't have that on. So.
All right, and one to go. What time do you wake up in the morning?
Oh, really late for an obstetrician.
Oh, really?
7:30 if I can get away with it, often because I've been up in the night. So
yeah, absolutely.
I've got colleagues who get up at 5 and I am not about that at all.
Well, thank you so much for answering those questions and everything today. It's been a fantastic chat. We've really enjoyed having you on sMater. Thank you so much for your time.
Thank you so much.
So for our listeners at home, in the car or having a well-deserved break between patients, thank you for tuning in. See you next time on sMater.